So I'm very pleased to be here today to present what in most ways is a wider look at what personalised medicine might mean, and it's been put on the slide as well, personalised care and personalised wellbeing. But in some ways, as you'll see, it's also a more specific and individual look at what we can do. And I'm going to try and make it specific to here in Leeds. Another thing I'd like to say before I start is that my slides have had a makeover since they got put into the pack. I am going to say much the same things, or pretty much exactly the same things as what it says on the slides that you've got, but it just looks prettier. Okay, so don't panic, because we've got some different slides coming up, and I will start now with the first one. This guy, he's not in your pack, very distinguished looking gentleman. His name is Paul Ehrlich, and he coined the phrase magic bullets. He's famous for inventing medicine, I believe. He was the first person who he invented medicines to target syphilis, and I believe was the father of chemotherapy. So before that time, which was about 100 years ago, people were treating the whole person. You were somebody with an illness and you would be treated with, I don't know, I don't think we were going quite as far as leeches, but people were treated with much the same treatments, I believe, whatever their illness was. So this was a start of targeting medicine towards specific diseases, and obviously it was a wonderful thing, and there's been a huge boost in our life expectancy and health since then. And now we're on the eve of another medical revolution in terms of targeted and personalised medicines. But I think before we go there, it's my job to have a bit of a reality check on, are we forgetting about the whole person in our enthusiasm for targeting treatments towards diseases and specific aspects of diseases. So I'm going to talk very much from a public health promotion perspective, and I've got three main perspectives I'm going to talk about. The first is wellbeing. At Leeds Beckett University, we're part of the Communities Evidence Programme, which is part of the new What Works Wellbeing Centre. So although we're not psychologists, we're health promotion people, researchers, we do know a little bit about wellbeing, and we do know a lot about community-centred approaches to health and wellbeing. I'm going to talk about health, and that's underlined because it's health as opposed to illness. So we're looking at what makes people healthy, what keeps people healthy, and what matters to people in terms of their health and well-being. And I'm, of course, going to talk about health inequalities as well, and how that relates to us in Leeds. Because reducing health inequalities is the main aim of the Leeds Academic Health Partnership. Okay, so what's wellbeing? What is it? What affects it, and why is it important? There are some definitions of well-being on here. The one at the top, feeling good and functioning well in life, I think most people will have heard. It's been attributed to the 5 Ways to Wellbeing by the New Economics Foundation. It's also known as flourishing, and you'll have seen it in lots of different reports. It's a very popular definition. Doesn't really mention health at all, other than the amount of health that you need to function well in life. The second definition right next to it is one that came from a 6-month collaborative development phase that we had as part of the What Works Wellbeing Centre with stakeholders. That's people who work in practice in public health with people in communities and in the voluntary and third sectors as well. We gave them a number of definitions, and that was the most popular one of what does well-being mean to you. That came out top, functioning well in life. For example, having a strong sense of meaning and feeling connected to other people. So there's a lot, that's about relationships as well as functioning. That's about the other people around us, so not just a single person, but how we fit in society and how society works for us. It's perhaps not too surprising that those definitions match, given that NEF is one of our partners in the What Works Wellbeing Centre. So, so they made sure to put that definition in, but it was the one that was chosen. The next definition down isn't actually a definition of wellbeing, it's a definition of health from the World Health Organisation. But as you'll see, it doesn't exclude wellbeing from health. It says health is a state of complete physical, mental and social wellbeing, and not merely the absence of disease or infirmity. So we don't just want to prevent people from becoming ill, we don't just want to treat people when they do become ill, but there's more than that. We want to make sure people are feeling good, have good physical and mental well-being, and functioning well in terms of having good social well-being, if we want people to be truly healthy. What affects our well-being? Individual well-being, we think, is affected by these 5 things, and those are the 5 ways to well-being that you've probably heard of, that were proposed by the New Economics Foundation. They are evidence-based. I know there's a bit of controversy about how evidence-based they are, but in my view they are quite evidence-based. Connecting, that's about, again, our social well-being, how connected we are to other people. I think most people know about the stats that came out from the Office of National Statistics that showed that it's beneficial for men in terms of life expectancy to be married, but it's not so good for women to be married. It reduces your life expectancy. That's a very well-known statistic, and it's quite funny, isn't it? And we can think of, I think we can all think of our own reasons why that might be. But what's perhaps not quite so well known, and maybe should be, is that there's some really good evidence in terms of a very strong meta-analysis of lots and lots of studies that has been reviewed by the World Health Organisation and approved of other types of connections. And it shows that being connected to the people around us, not necessarily in relationships with them or even friendships, but being on good terms with our neighbours and knowing who's in our communities, being part of that community, has a protective effect on our life expectancy, which I can provide that reference to anybody if they want it. Being active, there's a lot of, obviously we know that being physically active is good for our health, so I'm not going to go into that too much. Taking notice, there's something in there about mindfulness, but again that's a psychology perspective as well. Keeping learning, I think that's about being mentally active as well, and we already know there's a good evidence for that being protective against some of the diseases of older age. And giving, and that's in terms, again, that's part of the connection, I think, with our communities and with each other, giving something back. And again, here at Leeds Beckett we have a strong programme of research around volunteering and peer education and peer support, which is about supporting one another and giving something back to people, and the benefits that that has on the health of the people who take part in those activities. The next definition is again from the World Health Organisation, and it's about mental health. Okay, so mental health is not just the absence of mental illness, and mental health isn't well-being, but it includes well-being. It's defined as a state of well-being in which every individual realises his or her own potential, can cope with the normal stresses of life, work productively and fruitfully, and is able to make a contribution to her or his community. So there's that thing about giving back again, and about functioning, and about not so much feeling good. We're assuming that these are things that make us feel good and lead to that state of well-being. And then, after considering all that, there's community well-being, which is what we're all about in our role as the Communities Evidence Programme for the What Works Wellbeing Centre. Again, from our 6-month collaborative development phase, which wasn't just with stakeholders this time, but with people, real people in communities. These were the 3 aspects that were most important to people: people, place and power. So again, there's that whole thing about who you live with, who lives in your community, how well do you know them, how much do you trust them. So there's aspects of social capital and community capacity and community capital. What about the place where we live, the environment where we live? That's to do with the built environment, the amount of green space, the capacity for active travel, things to do with crime, fear of crime, how safe do we feel in the place where we live, how much rubbish there is. People always talk about dog poo. I don't know if you've noticed this. When we ask people what you think about where you live, that comes out all the time. And we find this in our work on community engagement as well. We've done quite a lot of scoping work for NICE on community engagement to inform their recent guidance. We could not avoid the topic of dog poo. It's important to people. This is what matters to people. And power. So that's about how much of a say do you think you have in your community? How involved are you? Do things happen to you, or do you feel able to take part? And again, that's something to do with functioning, isn't it? But also to do with how well we are and how confident we are. And a lot of that has to do with my next slide as well, about what makes us able to take part in society as much as we would like to. So the next slide is about health as opposed to illness. And I don't know if you'll recognise this tiny tiny version of Delbrin and Whitehead's rainbow of social determinants of health. And what it shows, it's just a diagrammatic representation of a lot of research that went into inform this, and I don't think it's been superseded really. Here we are, and here are our individual lifestyle factors that impact upon our health. And as somebody from health promotion, you might expect me to talk about those at great length, about, you know, eating healthily, doing enough exercise, not smoking, not drinking, taking time out to relax. That's all important, but what this shows is there's a whole load of stuff above that, the social and community networks, okay, so again, like our community well-being and our relationships with people, but also other things that are perhaps outside our control that impact on our ability to eventually behave in a healthy way and make those decisions and take control of our own lives as well as our communities around ourselves. Okay, so they're things like, I'm sure you all know, things like employment, things like education, things like where we live, housing, our environment, how able we are to get to services and access services, to do with transport, for example. This, we could think of, if we think of this in a medical sense, we could think of it in terms of prevention. Okay, rather than me talking about the social determinants of health, we could talk about preventing. What do we need to do to prevent ill health? Okay, because I'm sure it's probably more cost effective, and we'd all rather on a personal level not be ill in the first place than wait for people to become ill and then treat them. Okay, so what can we do to promote health and prevent ill health in the first place? These here are recommendations from the World Health Organisation's report on the social determinants of health. And this is the first lot of recommendations. There were 3 lots. These are the ones that I think are things that we can do something about in Leeds. And they're actually echoed in the Leeds Health and Wellbeing strategy as well. Improving our daily living conditions. We'd actually start with the best start in life. This commission that wrote this report was chaired by Sir Michael Marmot, and he would say, in fact he does say in his recent book, that that's the most important really, the best start in life, because any poor health that results from our circumstances is carried through with us and is amplified throughout our lives, and there's good evidence to show that. So targeting young families, people with babies, preschool children is very important, and there are plenty of things going on in Leeds that address that. Fair employment and decent work, very important, and it's not just being out of work that's a problem for people's health, but being in work that's demeaning, that's poorly paid, that's physically stressful. The circumstances in which you work are very important, and also insecure employment has been shown to have a detrimental effect on people's health and possibly on people's life expectancy as well. And that was shown many, many years ago as well by Michael Marmot. Again, I'm a big fan of Michael Marmot, but that work that he did, the Whitehall studies, that showed the people who had least control over their circumstances at work also had the poorest health. Good education is very important. Again, there's evidence to show that somebody who comes from shall we say, a deprived background can do almost as well as somebody who comes from who has much more advantage if they have good education. And healthy places, healthy people is about the environment in which we live and the people who live with us. Okay. Secondary prevention is about identifying people who are likely to become ill and stopping things from getting any worse. And I think there is a role here. This does fit with some of what we've been talking about before about personalised medicine. Certainly if you're talking about diagnostics and profiling people's genomes and things. I don't know much about that though, so I'm not going to go too far into that. What I can talk about is something that's being done in Bradford, which is called Bradford Beating Diabetes Intensive Lifestyle Intervention, where they're looking at people who are at risk of developing diabetes and working with them over a number of weeks, up to a year, I think. And that's showing quite positive effect. We've started to evaluate that, and it's starting to show that it is preventing people from developing diabetes, and those people who have got diabetes, it's also helping them as well. So that's just one example of ways that we can do that type of thing. We can also target people who are at risk of social isolation. We've done some recent work with Age UK, who've got an intervention called Together for Health, where they target vulnerable and frail older people and work with them in a holistic way to try and assess what they actually need. Rather than making an assumption about what we think they might need, they actually go work with the older person, treat them as an individual, and then signpost and direct them and take them to activities and things that they do need. And it might be something very practical, like they might need some handrails and ramps and things to stop them from falling and ending up back in hospital, and to help them get out and meet people. Or they might be at a stage where they do actually want to get out and take part in some activities and they want some extra transport and things. And that has been proved. That's reducing people's loneliness and social isolation. But there's also an aspect that doesn't work so well for everybody. There's also an aspect of personalisation even in there, which is that it's working better for women in some respects than for men, which sort of suggests that perhaps they need to think about doing some more targeted interventions for men. Okay, so with everything, there is an aspect of thinking about the individual and personalising every intervention towards the individuals. Testing, diagnosing and screening, I will come on to that later, about why that's important to target. And tertiary prevention, self-management for long-term conditions. As people are living longer and longer, they're developing more and more long-term conditions. So there's lots of people with more than one long-term condition. There's lots of things we can do to help people manage those long-term conditions. But in the same way, it doesn't necessarily, what works for one person doesn't necessarily work for other people. I think the expert patient programme had a very high uptake by what we call like white middle class people, but not necessarily for everybody. So again, we have to target things. Our work for NICE on community engagement and a lot of our other work on community-centred approaches has shown that something called cultural adaptation is a good idea, which is adapting your learning materials to what actually makes sense to people, whether that's language or whether it's not holding events at a time when there are religious things going on, or whether it's just providing childcare, for example, things that people don't think of. All of that makes a huge difference, and the way that we've learned that is by working with people. And that's what people like, is we go in, we talk to people, we find out what they want and we learn from them. And that was one of our recommendations to NICE in our community engagement work that we did for them which has made it into the NICE guidance, I think, respecting the knowledge that's already there in the community, that people already have. Okay, and community capacity and resilience, I think I'll talk about a lot as we go along as well, about how important it is to have those links and to build trust and relationships in the community. My third perspective, of course, is health inequality, and I think we're all here because we care about health inequalities. Two famous quotes: "Inequality affects us all," which means it doesn't do to just focus on the most disadvantaged. The inequality affects everybody. There's a gradient. We could all be doing better unless we're in that top 1%, which I don't think any of us here are, although I could be wrong. That quote's from The Spirit Level by Richard Wilkinson and Kate Beckett. The other quote is from the back of the WHO report on social determinants of health. Social injustice is killing people on a grand scale. Okay, and this is just one illustration of that. This is a map of the underground in Glasgow, which is also known as the Clockwork Orange. I'm not going to go over here because I can't. But as you can see, this is the area that's better off at the top here, and down there I think it's Calton, which is the worst off area in Glasgow. And so as you go along that tube line, you lose nearly 14 years of life expectancy for men, and around 8 years, just under 8 years for women, which is terrible because it's not that far apart, it's just two sides of the same city. In the slides I was going to show you, there's also a similar map for London. There's a similar map for Edinburgh as well, showing very similar things, and you may all have heard of the contrast between Kensington in London and Kensington in Liverpool. Again, I think that's of the order of 15 years or so difference in life expectancy. What you might not know is there's a 10-year difference in life expectancy in our city between Hunslet and Harewood, which I find quite shocking. I think we'd all like to do something about that. Okay, so what are our challenges for personalised medicine from my point of view? First of all, don't forget well-being. Don't forget the whole person. Integrate your personalised medicine innovations around all of a person's needs. Okay, because what we've seen in the past is that specialisation and targeting diseases means fragmentation. So somebody might have a hip condition and high blood pressure and develop cancer, and these are all treated separately instead of treating the person as an individual. Okay, so there's those sort of integrated medical needs, but there's also the needs of the person in society. And I was speaking to some colleagues earlier from the University of Leeds, from the School of Healthcare, who reminded me that they do this all the time. Nurses do this all the time. Think of people as individuals and think of their social circumstances. Some interventions might not work if you live on your own. You might need somebody else to help you with it. So they adapt the interventions to what people can actually cope with. Don't forget health. It's preferable to prevent disease in the first place rather than cure it. Look at a range of outcomes as well, because when we're used to looking at medical illnesses, we look at medical outcomes, what we refer to as hard clinical outcomes, like death probably being the hardest and outcome that's least in dispute. But other outcomes are important. People's well-being, people's happiness, people's feeling, sense of meaning and a sense of connection to other people. Don't forget about all of that, because that's important. Social determinants are what matter to people. They're the things that we want our health for. They're the things that make our life worth living. Use evidence that already exists. Our housing review highlighted that people are doing all sorts of important things to do with health and well-being, but very little of it's been written up and published as research or evaluation. But it doesn't mean that it's not happening. So learn from people who are already doing these things. We need to look a bit harder to find that evidence. Don't increase inequalities. Okay, so we all know about the worried well. My worry is that the worried well are the people who are going to benefit the most from personalised medicine. And here's quite a graphic example of the inverse care law from Birmingham, which shows that this map on the left is the people who went to see the GP about issues that might mean that they had coronary heart disease and were then registered with coronary heart disease. The white space in the middle is people who haven't got a diagnosis of a coronary heart disease, and the colours get darker when we get to people who have got that diagnosis. The map on the right is people who've died from coronary heart disease. It's almost the complete opposite. So the people who need to see the GP most, or who need that diagnosis the most, aren't getting it, they're dying first. So there's something to be said there for targeting treatments, targeting screening. And we don't know all the answers about how to do that, but it just shows how important. I don't want to be a wet blanket. My universe does serve as a wet blanket. Opportunities, I'm going to say this very quickly. There are opportunities to improve people's well-being, okay? And we've seen something in the news recently about depression drugs being targeted towards people who genetically there's an indication that they'll work best for, okay, in the same way at cancer drugs. But there's also the issue of person-centred care, and using the whole person approach can enormously improve somebody's well-being. Because there's no point being healthy if you're not also enjoying your good health. Promoting health and preventing illness. Early identification of people who are at risk is important, but we also need to target groups who we already know are at most risk of poor health. Okay, and that we already know that because of all these reports that have been done on the social determinants of health. Reduce inequalities. The people who are poorest improve their health the fastest. That's the recommendation in the Leeds Health and Wellbeing Strategy. It's filtered down from the Marmot Review, which then fed into the government public health white paper, Healthy Lives, Healthy People, and that came directly from the WHO report as well. So we're all agreed on that, but we just need to think of ways of doing that using personalised medicine. So perhaps rather than thinking of personalised medicine as a single magic bullet that's going to improve our health, perhaps we need to move on from that now and think of it as a magic bullet within a whole armoury of personalised and targeted approaches that we can take in Leeds to reduce health inequalities and improve public health and well-being for everybody.